Okay, thank you. Good afternoon, everybody. This is the January meeting of the Jefferson County Health Department Board of Trustees, being live streamed to the public. We have some board members here in person, some here virtually. But let's go ahead and call the meeting to order. We have a roll call, please.
Mr. Deal,
Here.
Dr. Henry,
Here.
Mr. Frater,
Here.
Peg,
I'm here.
here.
Okay, all board members are present, so we have a quorum. Dr. Henry, would you like to read the mission and vision, or would you rather have someone here do that?
I don't mind. The mission of Jefferson County Health Department is that they will champion positive health outcomes and behaviors through innovative programs and community engagement. And the vision is advancing the health and safety of Jefferson County.
Okay, thank you. Next item is approval of the proposed agenda.
I make a motion, we amend the agenda, taking the first one under new business building subcommittee, object presentation, and move it up to just before the director's report.
Can I have a second to amend the
I'll
agenda?
second that.
Okay, we have a motion and a second. Any other discussion on the agenda? Okay, hearing none. Everyone in favor of approving the agenda as amended, please say aye.
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 Anyone opposed? Okay. So quickly, we have some approvals to do. First is approval of the December 17th, 2021 board meeting minutes. All the board members were present at that meeting. You've all seen copies of the minutes.
I make a motion to approve said minutes.
Second.
Okay, a motion and second to approve those minutes. Any discussion on that? Hearing none, all in favor of approving the December 17th meeting minutes, please say aye.
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 Anyone opposed? Okay, that's approved. Next item is approval of the December 2021 expenditures. The amount I have is $150,105.55. Have a motion to approve those, please.
So
I make
moved.
said motion. Second.
Okay, a motion second to approve those. Any discussion on that?
Mr. Chairman,
Yes, ma'am.
looking at, on the 9th of December, Sandberg and Phoenix, legal services, 20,000. And there's another note here with some things on it, but this is a summary, and where's the billing detail? Because this isn't that detailed. It says 46 hours for a lawsuit. It also says board member issues, 4 hours, 1,100 hours. Well, the only board member there's issues with would be myself, and there was one email. So, you know, I'm requesting that there be a detail to this billing. Christie, do you have any problem with that? Mr. Chairman?
Ms. Davis, you've been offered the opportunity to be able to see the detailed statement. We cannot provide that in our open documents because of the fact that it does contain privileged information. So that is why the summary was prepared at your request.
All right, I would like a copy of that, please, before I leave today.
You can view them in the office of the finance, but you're not to make copies and take them with you.
Mr. Chairman?
Okay,
I find it quite excessive that our attorney charged us 46 hours and $11,000 within the month of December.
I can clarify that for Ms. Davis and for the community that may be confused about some of the comments that she's made here today and her ones on Facebook. That entry is actually not for the Cole County suit, as she has put on her Facebook page. That entry is actually to defend the suit that was filed against us. The Cole County suit has a separate entry that you can see down there that was for 7.65 hours.
Thank you for clarifying that.
Absolutely.
okay, so.
Curious to see what this month's bill will be, since you took it, to go after the Cole County.
Your request has
Case.
been answered, Ms. Davis, so. So we have a motion and a second on the floor to approve those expenditures. All in favor, please say aye.
Aye.
Anyone opposed?
I
Okay. 3-4-1. Next is approval of the December 2021 electronic payments. That amount is $489,766.31.
So moved.
Second?
Second.
Okay, discussion on that? Hearing none, all in favor of approving those December electronic payments, please say aye.
Aye.
I
Okay. And our last item is pre-approval for February 2022 estimated electronic payments. Estimated amount is $584,392.55.
I'll make a motion.
Second.
Okay, a motion and second. Any discussion on that? Okay, hearing none, all in favor of pre-approving those electronic payments for February, please say aye.
I
Aye.
Aye. Okay, those are approved. All right, so with the amended agenda, we'll have our architecture presentation.
Great, thank you. Slides up for it, that'd be great. Okay, so I'll go to the next one. I appreciate it. Thank you. My name is Jim Huber. I'm with Arc Images Architects. I'm one of the principal owners of the company. Along with me, I have Katie Kramer. She's our executive director of interior design. Since we only have about 10 or 15 minutes to talk, I'm going to make it real quick. I'm not going to let Katie talk, so I'll just go ahead and talk for her. So, again, thank you for having us. We really appreciate it being here. The rest of our team is my other partner, Greg. He will be helping us with the design coordination. He will be helping with the external design of the building. Joe Carey will be our project architect. Down at the bottom, Carl is with the MEP consultants that we will bring on board, which is with Rick Consulting. Jason Richards is our structural engineer from KPFF, and Brandon Hart will be the civil engineer from CEDC. We've worked with this team on many projects before, so we can pick them. We think they're going to do a great job for you guys on this project. Go to the next slide, please. We've been in business since 1988, so we're going on 34 years. I don't feel that old, but I guess I'm getting there. So we do have offices in Missouri, Kansas, and Illinois. We have 23 people that work for us in those three offices. Our experience, we're about 50% healthcare. We work with all the major healthcare networks throughout the area. And have ongoing projects with all of them. You can see a couple of those up here. We also do municipal work and educational work, which both probably end up being about 20 to 25% of our business. We also have, as you can see here, garage and maintenance facility experience. We worked with a lot of the municipalities in the area, as well as some of the auto body places that we work with, Dobbs and so forth. So we bring that experience to the mix. In particular, I just want to point out that the first picture up there on the bottom, on the top left side, that's a 3D rendering of the project that we're doing for Collinsville Public Works. I just wanted to, as we go through this, I just want to make sure that you guys understand. We've got the ability not only to do 3D images on the outside, but also on the inside of the project. We can walk you through the project. You can see what the rooms will look like, as well as what you stand in the middle of the room. And we can go 360 in that room, so you can really experience what that will be like. So for some of you that, and I know it's a lot of people who have hard time reading plans. I think that would be very beneficial for you to actually feel like you're standing in the room and really understand what that is going to look like. We've also done your High Ridge facility. So we've had some ability to understand your organization a little bit, what you're looking for, but also understand what you need from us in terms of assistance with the design all the way through construction administration. Okay, let's talk just a little bit about the design process. There are various stages of the design we have to go through in order to get all of the information from you for us to design. So it's programming, it's schematic design, it's design development, it's construction documents, and construction administration. The team you saw are all principal people in their companies. They will be the team on this project. We do not just put ourselves on the project and go away. We will be the team that will be part of this project. So we will guide you through each of these areas so that we can have a successful project. So our first thing that we need to do is programming and schematic design. We'll actually, we're going to look at this facility. We're going to walk it. We're going to understand what works here, what doesn't work here, what we need to change. We'll also want to interview you guys and understand what your needs and goals are. We do that with questionnaires. We do that with just meetings, walking around, looking at each of the departments. We'll suggest solutions and come up with a design. That's where design development and then we go into construction documents comes into play. Schedule is always important on these projects. And what we feel like we need from you guys is we need to know who the design team will be from your point of view. We would suggest that one board member be on that design team. We feel that it's important for that design team or for that board to be represented at those design meetings, so that when you come back to a meeting like this and somebody asks a question, somebody can answer where we are in the design process and what we're doing. More importantly, what's establishing that schedule is setting up all the meeting times so that we all know what we need to do. We all stay on schedule. And we understand when these board meetings are. Because at the end of each of those phases, schematic design, design development, and construction documents, we'd like to make a presentation to the board of where we are, not only in the design process, what it looks like, but also where it is coming in at in terms of cost. We will have a cost estimating individual on our team, and we will be updating that cost as we go through each phases of that design. We feel it's very important to report back to the board on where that process is, so that we can then, if we need to, we might need to adjust what the design looks like, or we might have to make some changes to that. We want to do that in the process of the design and not wait till the end of the design to do that. So again, we're here to kind of guide you through this process so that you guys can make informed decisions and we can get a very nice project for you. Okay, so we've taken a little bit of liberty on ourselves to kind of do a little bit of upfront design work. We know that you've purchased this site. I don't know if this is going to show up. It's really not very well. I'll go ahead and turn it off. So we know that this site slopes from front to back. which is from the bottom of the page to the top of the page. Slopes off quite a bit to the back of the site. We also know that you want to create maybe a building that's 24,000 square feet, and then another maintenance building that's 9,000 square feet. We also know that you're here to promote health. What better way to do that than be right next to the park, which is right next door. So how do we tie you into that park so that you can utilize that maybe for some of your activities? But also maybe creating a walking path or some kind of path around the whole facility that we can utilize not only for staff, but for the community to have a nice nature trail or walking trail around the community. So what we had looked at here was with this grade change, we have the ability to create a 2-story building and build it into the hill, meaning that that first story towards the bottom of the page and part of the sidewalls of that building would be built into the hill. That would allow you then to maybe put your conference center in that lower level, and that could become an emergency shelter for the community because it will be buried within the ground. The upper story would have a nice canopy out in front with a drive that would come through so that maybe if you needed to come out from the nursing area and do testing or do some of those things, your car seats and so forth that you might do for the community, you can do it under the cover of that front area. So what we looked at was 2-story building, area in front for parking, canopy. Then you go down the side of the building. We have a retaining wall there with some parking down at the lower end. Maybe some kind of gate or fence around the parking garage, parking area in the back for your vehicles or vans. And then we have your maintenance garage down there. We then looked at, go ahead. Thank you. We also did a little block plan of what that might look like inside the building and what you could do. So we have an entry there at the bottom of the page. Off to the right, we showed the nursing area, and that would then have the ability to connect right under that canopy up front. Conference facility and boardroom there off the main lobby, so that the community can come in if we need to, if we're going to have meetings and so forth. And then off to just above that boardroom, we looked at the possibility of maybe putting the staff break room or a kitchen area there that could be right off the boardroom. That could be used not only for staff breaks, but could also be used for presentations and so forth if you wanted to have food and drink for that. From there, there's a central core area of bathrooms and elevators and stairs. And then we looked at administration and accounting, maybe being up on this floor with some support space and hoteling. Hoteling being a place for offices to be placed for people that might be coming in and go get an office here. The lower level, the upper right portion of that would be the entry into that lower level with the 2 conference education rooms. That would be one large room that could be divided with a divider. So it could be 2 separate rooms. We have that core area coming down below. We also have a community kitchen down there that could be directly adjacent to that conference facility. And then we have some of your labs and health network and some of those other offices down in that lower level. Again, this could be used as a storage shelter. By the way, it's going to be built into the ground. And then finally, we just wanted to show you what it might look like. We did some 3D images of what a building might possibly look like here. There's your canopy on the lower image that you could drive under. Maybe have a clear story up above so we get some natural light into the building that can go back as far as we want it to. We see the retaining wall off to the right, which then goes down to that 2-story space down below. And then on the back side, we've got your entry in that upper picture there in that left-hand side. Kind of gives you an entry into that lower level. Again, some natural light up above coming into that space. We can change materials, we can do all of those things. I think what we're trying to show you here is actually a possible image to what it would look like. But then also that we can do this in 3 dimensions so that you can start to see what it looks like. We can put this onto the site, you can look at it from up above, we can rotate it down so you can see it on the site, walk around the site and see the building. We have the capabilities to do all of that in terms of a 3D presentation for you to help you really visualize and understand the building itself. And again, we can walk through those front doors. And we can take you into that main lobby, we can take you into the boardroom, we can take you into some of the office space so that you could actually see what that would look like in terms of walking through the building. Yes,
You know, the public are going to be interested in how large the boardroom would be.
how large it would be? Well, I
In
think what,
comparison to this room or to the county's administration.
I think the boardroom size would probably be bigger than this room. I think what we would need to do is understand the number of people you want to accommodate in it and then size that for that space. So that's all part of that programming process of trying to understand how big you guys do want the experience and how many people we need to accommodate. So, and also with the conference center too. Okay. That was a very quick presentation. I can talk for a long time, but I did it real quick. I'm here to answer any questions. Let me just, one more thing before I forget. Schedule wise. We proposed the schedule of 5 to 6 months for design. We think it would be good for us to try to meet every couple of weeks to do that. So again, we want to get that on the schedule so that we have everyone scheduled and we know what we need to do at each of those meetings. We'll develop a work plan that associates with those dates and what we want to accomplish at those meetings. Probably bidding is going to take another 3 to 4 weeks for bidding. In terms of after that, you go select a contractor. Depending on how long it is for contracts and so forth to take place, that could be another month or 2 weeks, 3 or 4 weeks, whatever that might be. And then we're seeing probably a 12-month building schedule. Maybe we get it down to 10, but it'll probably be about a year for construction. We are in an interesting market right now, as everybody probably knows. Materials are hard to come by in some spots. So we'll continue to look at that throughout the design process and see if it might be better for you guys to pre-buy some things. To help save some money, but also to get it here in the time that we need it to be here. So we'll talk about that as we go through this.
Where would we store those
That's
materials?
a good question. I think what would happen is that you get it on the schedule and let's say a rooftop unit that we would need. Rooftop units would take them 3 months. By the time that you would need that, you'd have location on the site that you can store it. So construction will have begun. We can store it at the site and then put it up in the. That's our thought process. Any other questions or anything I can answer? Any quick little
You mentioned the time phrase for the different stages. What total time frame are we looking at?
So I'm thinking, again, 5 to 6 months for design of the building. So schematic design and programming usually goes pretty quick. That'd probably be a 3 or 4 week, probably about a month. Schematic design, that would be another month. Design development would be probably another month and a half. And then construction documents usually takes 2 to 2.5 months. So that would round us out right around that 6 month period. And then we go out to bid, and bids will probably take about a month to get that from the contract.
You said a year for?
Yeah, 10
construction?
months to 10 to 12 months for construction. Is what we're anticipating.
So more or less 2 year.
Yeah, it's probably about a 2 year project. Yeah, 1.5 to 2 year project. Yes.
And I'm not sure if Steve or but anyone else on the committee may be able to answer. So as far as vehicles under roof are concerned, we're gonna have room for what, the vans and
The larger vans we're planning, hopefully to have room in the outbuilding, but we don't have anything. And this is just a preliminary. I mean, we've not really sit down and gone through any design with, we haven't even picked firm yet, so that could be something we can look at. Outside canopies for the fleet vehicles if we wanted to look into that.
All of that will start investigating the programming, to understand what you want to do. And then with that first budget, you'll see how much that was going to cost you. And then decide if that's something you really want to spend money on, if there's something else you want to spend it on. So that's why I think meeting with you guys and during those different periods of design will assist us in understanding where we want to spend that money in the right spot.
is there any way, knowing what you know at this point, to give a ballpark estimate of what the project is going to cost?
I think I think what came out in the RFP was a $10 million all-in project budget. And by all-in project, I mean construction fees, furniture, equipment, all of those things. So roughly, the building is probably about $300 a square foot. The outbuilding is probably going to be cheaper than that, which is the garage, the 9,000 square foot garage. That's probably in the 180 to 200 range, probably. Just giving you rough estimates at this point.
And the 2 million also included the preliminary site of the soils and making
It's
sure.
going to include all the soils, it's going to include all the soil borings that we're going to need. So really, what we want to try to do is site this building on this site as quickly as we can, so we can do soil borings. We need to understand what kind of material we're going to be building on. Where is rock? Is there rock underneath us? How was the fill that was placed on that site when they filled it in? So we need to understand what's there so that we can design the foundation systems to it. That then helps us to understand what that cost would be for that amount of work. It's a lot to be done very quickly.
Any other questions?
Any other questions or anything?
Mr. Chairman, were there bids put out on this company that we're listening to today? There are 3 bids put out.
We haven't done bidding yet, have we?
Well, we didn't do it. We didn't do a bidding, but there a process on the architect. We used a qualification,
This request for qualification, sorry.
which is the standard. And we did go through, I think we had 11 firms that submitted. And then the committee narrowed it down to 3 firms. We brought those 3 firms in and interviewed each firm individually. And the committee members scored those. And we chose the firm that we felt that we wanted to present to the board, which is Arch Images. And then they've given his presentation, and the board will meet and decide if they want to go with this selection, or we'll bring in another firm to review them.
So, and the committee is yourself and
Big and James, Kelly and Jetty both sat in on the review, and Christie sat in on it as well on the interviews.
Gotcha.
Well, thank you.
Okay, thank you very much. Appreciate it. Thanks so much.
Thank you very much.
Thank
Thank you.
Take care.
Okay, next item on the agenda is our director's report.
Melissa, would you like to make clinical services?
Sure. Am I okay to sit here or would you like me to?
So the camera will do it better on the. This is number 4. Do you have a copy of that somewhere in our packet here? Number 4. So where's the option? Oh, this is it, of number 4.
You're on it.
Communicable disease order.
That's not number 4.
This is on it.
Yes.
This-
What is number 4 under
The
director's report?
communicable disease order.
Under
Do we
new
have a copy
business?
of that somewhere?
She's looking at new business number 4.
Oh, new business, I'm sorry.
It was emailed out.
It was emailed out, and do we have hard copies? We'll have hard copies by the time we get to.
So we won't have it in front of us today?
We don't have it in minutes.
Davis, you will have it in just a moment. It was emailed to all board members.
Good afternoon, everyone. For the January clinical report, I'd like to focus on the COVID-19 testing that we perform at the Jefferson County Health Department. So the report you received in your packet has some information on how our testing is done, the methodology, and then some graphs on what testing looked like throughout last year. And so I'd like to also talk a little bit about what we're seeing now when we get to that point. So just some background. We've been doing COVID-19 testing here at the health department since April of 2020. We started doing the testing through a program with the Missouri Department of Health and Senior Services, where they partnered with us to provide an instrument, and they're providing test kits. And they have continued to provide test kits for us throughout this process since that time. So we are currently using an online application process, and anyone in the county can go online and fill out the online application and request to have a COVID-19 test. We have an entire team that reviews those online applications and contacts people, whether by email or phone, depending on what they prefer. And then we set up appointments based on our availability. Most of the testing we've done over the last year has been done through our drive-up location at our Arnold facility. And the team spends minimal time with interaction with the patient, just to collect some basic information that wasn't collected on the phone, and then also to collect the specimen and get consent. And then the test itself typically takes 15 minutes or less. And results are provided both verbally on the phone as well as through a secure, HIPAA secure email system. So we provide a copy of the test results so that the individual can use that however they need to. The type of testing we do is a rapid molecular test. It uses an isothermal reaction to detect the RNA of the virus. This test has a sensitivity of greater than 94% and a specificity of greater than 98%. So when you look at the testing we've done over the last year on page 2 of the report, you can see that the highest number of requests we've received and the largest amount of testing we did was January of last year, and then again in December. Just to compare that to what we're seeing now. So our highest month last year, we received 517 requests for testing. Through January 26th of this year, we received 866 requests. So this is just preliminary. Obviously, we haven't finished out the month. Last January, we performed 209 tests. This January so far, through the 26th, we've performed 334 tests. Last January, our percent positivity was 22%. So far this January, our percent positivity is 45%.
How do you arrive at that percent?
The percent positivity. So we take the total number of tests that we performed. You take the total number of positive tests on top of that, and then you multiply that times 100.
The number of tests performed plus the positive test?
No, ma'am.
No.
Number of positives over the total number.
Okay.
So just to give you guys an idea of the resources that we have committed over the past year and the impact that that's had on the community. Some of you may be aware that there has been a significant increase in demand, and just our availability to have that test in January of this year and be able to meet those 334 test requests has had a significant impact on the ability to receive tests in our community. We have shifted resources multiple times over the past year. We have an excellent trained team to perform those tests, and all tests are reviewed by a clinical laboratory scientist, and we have a medical director who is the medical director on our CLIA certificate that reviews and signs off on procedures. What questions do you have?
So when So tests come in different places. They come from the hospital, they come from
No, ma'am.
people coming into you, just the people that come into you.
This
is what you're
is
talking about.
specific to the testing that we perform at Jefferson County Health Department.
Mhm.
So this is only the people that we see.
Okay, so that's what you're talking about, okay. And in-house, we do the actual development of the test to find out the findings. It's a rapid test.
We do a rapid molecular test, yes. So we do the specimen collection,
Mhm.
we do the testing on site.
Okay,
And
and
we
exactly
provide the
what is
results the
done.
same day.
So you received a test from somebody that came in, and what exactly do you do to process that test? Oh, teach us.
Sure. So we collect the specimen outside.
Right.
With full PPE on. We use a nasal swab collection.
Right.
We go directly into the laboratory, which is attached to the outside collection site. And we have two ID now instruments that perform the rapid molecular test. And we have trained staff inside. So we take the specimen and use the test kits and the instruments provided. We follow the procedure exactly as the manufacturer has directed.
So does that swab get dipped into something and put into a test tube and then put into a machine that shakes it around, or what exactly happens?
No, ma'am. So the swab is used directly into the test system. We don't use viral transport media.
Okay.
We don't take time to transport the specimens anywhere. We collect it and test it directly afterwards.
And is it a machine? Is it, what
Yeah,
exactly?
it's a small point of care instrument. It's about this big, about that high.
Okay.
It sits directly on the counter.
Mhm.
We have test kits. The kits come in a 2-phase.
Mhm.
Okay. So the first phase, we put the swab into the lysine buffer.
Okay.
And that's where the heating takes place. And then we have another set that goes on top of that pipettes the fluid from that, puts it into the second piece, that does the replication and the detection. And it all takes place inside the analyzer. And it's all within 15 minutes.
Melissa, I have a quick question.
Yeah.
And I apologize if I missed this, but the blue is the number of applicants and then the number of tests. Are those because we don't have enough tests in time to get to all those individuals? Or did you do some kind of survey to see if they had the symptoms?
Yeah, so that's a great question. So it's a combination of things. We only get so many tests from the state, so we can only get the amount of test kits that we receive. But we're also looking for symptoms. So our test, we know, performs better with individuals that are symptomatic and are within 7 days of having symptoms. So we are doing some screening when they fill out the online application to ensure that they meet that vendor criteria to be able to perform the test. A lot of times, because in the last year, there has been a lot of other testing options in the community. Sometimes they fill out the form and by the time we call, they've already found testing elsewhere.
So have we hit any period of time where we were not able to provide the services because we just weren't getting the number of tests we needed? Are you doing okay at this point in time?
We're doing okay. We're keeping a close track on it right now. And luckily we've been working with the state and they increased our shipment of kits this month because we were running really close, but we were able to get a larger shipment of kits and we're doing okay as far as volume goes right now.
Well, thank you for all your work. This is wonderful.
This is just for everyone's information too. A lot of folks may know this, but the state, I believe, is providing tests this month, 1 day a week at the Hillsborough Civic Center on
Yes,
Wednesdays. Is that correct?
yes, they started this week. It's a drive-through specimen collection site here at the Hillsborough Civic Center. It is a state-sponsored site. They're working with contracted laboratories, so they do the specimen collection on site through that drive up, and then they send the specimens for PCR tests. And usually the individuals have results in about 48 hours.
you have anything else?
I have nothing else. Any other questions?
I had just had one more to just help me wrap my brain around this fully. So the positive tests that we're reporting in this report, it's not this page, it's the other one looks like this page, right? That is consisting of the tests that come back from the state and from the
No,
hospital,
ma'am.
just from here?
Just from here.
Okay.
Yeah, this entire report is only for the testing that we did here at our agency. It doesn't represent any other testing done around the county.
And then the formula that you gave me was the number of positive tests over the total number of tests, and then did you say times 100?
Yeah, you get a percent. You get a percent.
And then times 100, or do you mean move the decimal place twice?
Yeah, that's what that means.
Okay.
Okay, thanks, Melissa.
Okay, thank you.
Thank you.
Okay.
Thank you for having me. So again, I'm Jacqueline, the Community Services Manager, and I work with our environmental and health network programs. So in your packets, you will see the monthly environmental report and the health network report. I do want to draw your attention to the second page of the health network report under drug prevention. Just wanted to let you know we've been having incredible success with some new programs regarding homeless populations. Our drug prevention specialists, along with our vulnerable population specialists, have been working with multiple providers in our community to locate where particular homeless populations may reside and going out to them or close to their area and providing a number of resources, including healthcare, dental care, access to treatment, access to housing resources, clothing, blankets, tents, food, anything that they might need. And so in December, we were at Festus Walmart on December 7th. At that one event, they were able to assist 15 adults and 5 children get essential items, including dental care and some other pieces. December 21st, they assisted 14 adults and 7 children at the DeSoto Community Center. And again, same thing, they had an array of resources there and people were able to access them. We do have an event coming up on February 1st from 11 to 1 at the Arnold Food Pantry. We are anticipating a number of individuals and families to come. And we will have more information next month for a January event. Some of those were very large, up to hundreds of people that we were able to serve and provide items for. And some exciting news, the Department of Mental Health through Palm Tree, we were able to receive $300,000 through a SAMHSA disaster response grant service. And this is going to help us continue to develop our resource navigation tool that has a mental health platform. So we've talked about this before. It's a really exciting virtual platform. Right now, we're working to launch very soon in some of the schools around our community. We had received grant funding in 2020 and 2021 from the Jefferson Foundation, from DHSS Overdose to Action, and through the Missouri Foundation of Health to get it to the point where it's at now. So we're excited with this additional funding. We're going to be able to expand services and components to foster children, first responders, healthcare workers, including public health workers, where we'll be able to access unique assessments and resources to help with burnout rates and to help with some of the struggles that many healthcare workers are dealing with, especially through the pandemic. And we will also be working on developing a resource navigation tool that we're hoping by 2023 will be available to the community. So we're really excited to have this opportunity in partnership with Palm Tree to receive this funding. So any questions on that or anything else I have in the reports? Thank you very much.
I did have a quick question.
Sorry.
I was wondering if you could tell us how the public would be able to access like a Narcan shot or something like that if they needed it.
So yes, we do have drug prevention specialists that are trained and have access to Narcan on hand. Or if an individual or family would like to access that to have on their hand, they can come to our locations. They can call our 636-797-3737 number and set up an appointment with our prevention specialist. They will receive education on how to utilize the Narcan, and they can walk away with Narcan in their hand if they choose. It will be utilized if needed.
What is Narcan? Sorry.
Oh, that's okay. If someone is suffering from an overdose and it is related to an opioid such as heroin, Narcan can be utilized sometimes to be able to save a life. So it is, yeah. Our drug prevention specialists work with Prevent Ed and other agencies throughout the area to obtain Narcan through grant funding and be able to educate the public on how to utilize it.
Thank you for the answer. Appreciate it.
Awesome, thank you. Any other questions? Thank you.
Thanks, Deb.
Okay, while Jetty's passing those out, we'll go ahead. The next item on the agenda is the 2021 annual report. The annual report will be available on our website, as it always is. It will also be distributed to lawmakers, to the community, and other community partners. But again, just wanted to take the opportunity, this year, we really highlighted all of the activities and programs that we have been able to continue throughout the pandemic. So even though it may seem like our whole focus and response has been COVID, our staff have been very passionate about keeping up their projects and programs in order to be able to ensure that the public has those kinds of has access to resources. So things along the lines of, our family planning, Show Me Healthy Women and Wise Women, which help to provide screenings and services to help individuals who are uninsured to be able to access things like mammograms, or to be able to go through things like nutrition counseling. Looking at our vaccinations, providing over 3,500 vaccinations to individuals, whether that be kindergarten shots or looking at things like flu shots and otherwise. We have, in terms of looking at our COVID vaccinations, we had over 23,000, almost 24,000 vaccinations that were provided during the last year. Looking at communicable diseases, again, that'll be something we'll talk a little bit more about, but on page 10 of our annual report, you'll look at the kinds of communicable diseases and the rates that we've had as far as the last 12 months. One of the things you'll notice at the very bottom is in terms of our influenza cases by CDC week. So thankfully, we're looking at right now, we had an earlier influenza season. It was milder compared to our previous seasons, aside from last year, which was pretty much non-existent. One of the things that we're trying to keep in mind is that the typical season is usually October through March. And so, and our area typically doesn't normally see flu until usually January, February. So there still is that opportunity for this to reemerge and come back. But at this point in time, we have experienced an early onset of flu, and it seems to be waning back down in the community. So that's a good sign, but encourage folks to still continue to go ahead and get those immunizations. Again, I'm just trying to tap through a couple of these, but our vector surveillance. So we've significantly increased our mosquito spraying treatments this year. We had a 65% increase from last year in terms of doing spraying throughout the community. But a significant amount, 257 animal bite investigations, which we will work with to do rabies testing if necessary, but as well working with the individuals that are impacted by that. Dental services on our next page, looking at both our youth van that goes out to schools, but then as well our Senior Smiles van, which provides everything up to and including dentures for older adults who are in our long-term care facilities, as well as individuals in the community. A couple of our lesser known programs that we provide are our adult brain brain injury program, which works with individuals who have experienced a traumatic brain injury. And we do everything from case management to referrals and assisting individuals with accessing services in the community, as well as a similar type program for children with special health care needs. So individuals perhaps that were born with a birth defect and who are working to try to access resources. Going through the end of our program, we've got some stories about types of programs you're hearing about today. The Aspen tool, which is what Jackie was just talking about with our community services, and the mental health programs that we're looking at building for youth in schools, for foster care youth, and for our first responders, as well as looking at things like our wellness walks. We partnered with the Peace Pantry and actually have walking on their walking trails. We have the signs up, which will help to guide families through different levels of exercise. Our land purchase, which was also brought up today. And just looking in, again, our addressing opioid epidemic, looking at Narcan training and opportunities for people to access services and COVID response. So I encourage you to take a closer look through that and really get to know the health department. One of the things that I addressed in our initial letter was that, yeah, I appreciate if you put your mask back on as policy. Thank you. One of the things that I really addressed in the director's letter was the fact that it was really unfortunate that the community got to know public health during a pandemic. Public health is so much more. The education, there's environmental pieces, and our nutritionists do free nutrition education with individuals. And so really, we are a very well-rounded practice, and I really encourage everybody to look and see the resources that we have in the community. The next item on the agenda is the audit. You should have a green copy of the annual audit in front of you. There was only one listing in the management letter, and that was for the timing of the audit. The several factors played a role in the audit being completed a little bit later in the year than it normally is. One of those was that we had changed accounting methods from cash to accrual, which facilitated a lot of changes in the way that we had redone our methods of reporting. We changed our accounting software from QuickBooks to MIP, so that all happened in the middle of that. COVID vaccination clinics at the very beginning of the year, we had all hands on deck. So we actually had to really physically pull almost all of our staff into those clinics to be able to manage until they started to filter back. And then a number of the number of monthly and quarterly reports doubled in 2021. So because of the additional funding coming in, it increased the workload full flow for our planning. But aside from that, accountant was happy with our services, came back with a clean report. And so just kind of giving you that information. But you have a copy of it for your review. And if you have questions, we can make arrangements with Kristen, who was unable to be here today, to answer any further questions. And then the final thing, if you don't mind pulling up the PowerPoint. We have some very energetic youth in the lobby today. I'll pass this down. Do you mind passing this down? Okay. And okay, so the communicable disease report, as we are looking at the overview. Okay, go ahead. So the first thing that we will address is looking at our COVID numbers and our So as far as looking at our COVID update, again, just looking at week 3, things are looking better. It's nice to be able to say that, even though everything is still in red. But we are starting to see a plateau and somewhat of a decrease in our numbers. So this week, the county does remain in red with a weekly case count of 2,495 confirmed and probable cases. It's the second week in a row that we've seen a small decrease in cases, but the percent positivity is continuing to stay pretty strong at 36.27%. One of the things that, one thing is that we do still have a lot of virus in the community. The other piece of that is we do not know how much of an impact the home tests are making in terms of the numbers of, or the positivity rates.
And we do know that vaccinations are driving.
Ma'am,
the
I'm
illness
sorry,
rates.
but
Vaccinations are driving the illness
Ma'am.
rate.
We do not have a public comment section. If you cannot simply observe and quiet, you'll be asked to leave. Thank you.
so it's important to know that the home test may be affecting the weekly case counts and our positivity rates, because individuals are not required to report home tests. We do have the opportunity on our website for individuals who would like to report their home tests or their home positives to be able to enter that information. And those cases come into our forms as suspect cases. So they are not included in the probable and confirmed cases that are reported up here. Of the 2,495 new cases, 63.45% were unvaccinated. So again,
By definition,
ma'am, you may be removed from the.
By definition of the vaccination, can you tell us how many people?
We need to keep the draft of the ordinance.
Yes, she may not take the draft of the
I
ordinance.
can take
with
the
her.
mask off because it's a lie.
You may not take the draft of the ordinance, ma'am.
I need that
She
draft.
can have the ordinance once it's approved. If you change the street, it's a draft document. It's not public. Because you should not have handed that out.
Yeah, because you guys
Ms. Davis, you were informed.
Voting on it today.
Ms. Davis, you were informed that you were not to distribute that.
Before it gets voted
No,
on.
it doesn't, ma'am. It doesn't.
Yeah, it does. This is some serious shit. This is
Ms. Davis,
terrible.
this information that was presented to you in this draft was in writing, was
this
told to
has
you
to
that you were
be
not to distribute this
Presented
form
to
to
the
the public.
public before we even think about voting on it.
You don't understand.
This is talking about having people arrested, et cetera, et cetera.
It's the same thing that's always been in place.
No, it's not.
Yeah, it is.
No, it isn't.
Mr. Thiel, can you please ask for control of the room, and please have the floor back.
God bless.
Thank you. So the, of the 2,495 cases we reported in week one, 63% were unvaccinated. So again, what we're seeing is high numbers of individuals who are unvaccinated are testing positive, as well as the majority of individuals who have been hospitalized or unvaccinated. We have seen a 36.57% who have received. When it says fully vaccinated, I want to clarify that means that they've either received the 2 doses of Moderna, 2 doses of Pfizer, or the 1 dose of Janssen. Fully vaccinated at this point does not mean boosted. So there is a distinction between fully vaccinated and boosted with the additional dose. What we are seeing is for those individuals who have chosen to get the booster shot, only 9.9% have tested positive. So we are seeing significantly lower rates of disease in those who have received the booster doses. As far as the vaccination rate, 53.53% of residents have initiated the vaccination and 48.9% have completed the full series. Again, the full series would be 2 shots. When we are looking at the 3rd dose or booster dose of the vaccine, only about 17% have received that booster vaccine. So right now it's a pretty small number, which is not going to make a significant impact in our numbers as far as trying to bring those down. Next slide. One of the things, this is the COVID-19 emissions in the St. Louis metropolitan statistical area. So this information is from the St. Louis Pandemic Task Force, and it shows, Brianna, if you don't mind, putting your cursor over those initial ones, and yes, right here. The first wave that we saw, actually go just a little bit more, there we go. So this is the first major wave of the COVID-19 virus. So this was December of 2020. When we experienced the first major wave, going up and going more towards July, August. This is Delta. So again, this is the daily new admissions, and then the black line is the 7-day rolling average of daily new admissions. And I want to show you the difference of Omicron. So this is Omicron. So we have seen significantly more hospitalizations, significantly more cases with the Omicron variant this last time. Again, we are tentatively hopeful that we have seen the peak and that we are starting to see a decrease in our caseload. Next slide. I wanted to show, so that was the St. Louis metropolitan area, just as a quick couple of slides. This is Jefferson County. So again, that was our initial rates of cases in December of 2020. That's our Delta wave. And then this is Omicron for Jefferson County. Next slide. These are cases by week, by age. So on your left-hand side, you'll see that all ages cases by week. But the one thing, again, just showing is that our youth, one of the things people tend to think is that our youth are not impacted at the same, they're not getting sick as the others are. I want to show you that, especially with Omicron, we are seeing the very same trend lines from the very beginning of the pandemic to now. Next
Tell
slide.
me what ages are included in youth?
In youth, it would be ages 0 to 19.
Thank you.
This is just showing the impact of vaccination. So in Jefferson County, this is a 14-day, basically looking at a previous 14 days. And so with Jefferson County, the map on the left is showing vaccination rates. So that is the percent of the population that has received the 2-dose vaccination. So the darker the color, the more people who've been vaccinated. The lighter the color, the fewer people that have been vaccinated. When you look to the right, what you're going to see is our cumulative case rates. So again, on the right side, the more cases are darker colors, fewer cases are lighter colors. And you'll start to see, if we go to, and one thing you can note is that the cases tend to run down the highways. So down 55, down 21, down and across Highway 30. We've seen this throughout the pandemic that it tends to follow the travelways throughout the state. Next slide. The one thing that we were looking at is just kind of, a lot of times what we do is do analysis to see how this plays out. So what we're looking at with the blue map here is all census tracts with less than 50% completed vaccination, plus our census tracts that have a cumulative case rate that is in the highest 20% of the state. So again, significantly higher case rates. And the areas that are circled, so I don't know if you can see that. So down by Jefferson R7, looking in on Hillsborough, yes. So those areas, those are the areas where we are seeing, we have low vaccination rates, and we also are seeing extremely high cases. So we are seeing a correlation between low vaccination and high case rates. Next slide. One of the things I just wanted to point out is, I know it sounds like we really focus on COVID a lot, and we do a lot of talk about it, but I wanted to bring up the fact that in your packets, you'll have some information from Brianne as far as our, or it may not be in there, okay, we'll add that. So Brianne has been working on some analytics, looking at our socials and how people are accessing us. And one of the reports that she had is, what are users looking at when they come to our website? So we had just over 25,000 individuals who accessed our page and landed in through the homepage. Of those, we had over 19,000 that went straight to the COVID data. So people are interested in COVID. One of the things that we are finding is 64% had come to the website for COVID information out of the 25,000 people who viewed our site. 65% of those are looking directly at COVID information. So it is something that is still of major interest to our community, and they're looking for more information. And that was, thank you. And this was for December 1st through 31st. Next slide. So I'll skip this one because you guys had it in your report. So the things I'm going to finish up with are talking in terms of our communicable disease rate. So one of the information that we're giving you now is from our annual report. So our annual report is actually broken down and made a little bit more simplistic in terms of looking at our enteric reports versus whether, how somebody acquired an illness. This actually lists out the diseases that we have been working with. So we had 124 confirmed and probable cases throughout the year. And these are all the different diseases, everything from pertussis to salmonella to shingles to staph, looking at the different diseases or conditions. When we look to this right, one of the things that is important to know is that the confirmed and probable, a lot of times there's a lab or there's something that makes it's very easy to make that confirmation. What takes up a lot of time are those non-cases. So those to the right that are a no case or a suspect case where there isn't enough information or there isn't enough data to be able to confirm that it is, to call it a case or to call it a probable. And this language came in a lot when we were dealing with COVID, and we keep talking about like what kind of test it has to be and why we're gathering it and what makes it a probable or a confirmed case. This shows it for all of our other communicable diseases in terms of every single one of these requires us to do an investigation and as well as to be ready to immediately go into a response mode if it is something that can be highly contagious. Next slide.
Kelly, can I ask a quick question?
Absolutely.
On the Rocky Mountain, go back to that slide.
We're almost there. Hold on. Rocky Mountain spotted.
Yeah, it said there were 40 cases suspect. Is that something that's difficult to test for, or why would there be such a discrepancy on that one?
Rocky Mountain spotted fever, I will double check with the CD team. It may be something, I believe that's a blood test. But I'm really sorry.
That's okay.
I was gonna say, Brian's fever is rebelling against it right now, so.
It doesn't like anything I do.
Can you use your arrow keys?
You know, right? You're clever.
There we go.
Okay. Get it.
So Rocky Mountain spotted fever, there were 4, and then suspect. So again, that may be something where another piece of that, and I will say this is speculation, but it could be where they had signs and symptoms and they were treated for the illness without actually going through the diagnostic confirmation of the test that's required. So sometimes that'll be a case where that's sort of like when somebody has COVID and somebody else in their house develops the symptoms, they may go ahead and treat them as a probable case, but they're not, or they may say, we think you have this, but if they don't go through the process of getting tested, then we can't confirm. Okay.
Thank you.
So, no problem. So the next slide is blurry for those who are trying to look at it, but it's more for the effect. There are 135 cases in the statute 19-20.020. So those are all of the infectious, contagious, communicable, or dangerous diseases. Those are all of the communicable diseases that we are responsible for reporting on. So we have to do investigations. We have to do all of the work around those. Of the 135 cases, we've addressed 54 of them. So 40% of those diseases, besides COVID, which is number 3 on the first column. All of these other ones, botulism, measles, hepatitis, looking at giardia, gonorrhea, strep. So anything and everything, malaria, mumps. These are all things that our team has done investigations on. So it's important to know that when you're making decisions about the communicable disease order that we're getting ready to put into place, this is everything that it touches. It is not just COVID. So, okay, next one. So one of the things, there were just a couple of points, and I know I've made this a little longer, but I really feel it's important for people to understand the impact that the Cole County case and these decisions that have removed the ability to do isolation, quarantine, and case work with communicable diseases. It is so much more than COVID. COVID is really actually, ma'am, if I can finish. Ms. Davis, I have the floor. Thank you.
You just stated that it removed the ability to do quarantines, et cetera, with all these other diseases. It did not.
Yes, it does.
It was specific to
No,
COVID-19 and the masking of children in schools.
Yeah, no, it was not.
no.
Yes, it was.
No, ma'am, it was not.
Okay, let's move on. Kelly. go ahead.
So the Cole County case actually physically removed those components of the law which allow you to address communicable disease. So again, if you don't mind going back to that page.
But there must have been a reason for it. or they would- or they wouldn't
135,
have
Miss
done that.
Davis,
They
100,
saw some danger
Miss
in it.
Davis, man.
You're out of order.
So I'd like to, just in doing this, I'd like to read so on the first section, they're immediately reportable because they pose a risk to national security because they're easily disseminated. They are transmitted from person to person and result in high mortality rates and have a potential for major public health impact. Another one of them is looking at instances, clusters, or outbreaks of emerging diseases. So being able to look at things where we may not necessarily know what we know that it is something that is enteric. We know that it's something that's spreading and it's causing a major impact in the community. Having the ability to be able to do this investigation and be able to work to identify the source helps us to prevent it from impacting others. So the goal of communicable disease, do you want to move to the next one? The goal is to really get you back to your normal life as quickly as possible. I mean, that's literally the first thing that our communicable disease nurse says when she talks to somebody. And the most frequent people that she talks to are individuals with TB cases. COVID is really an outlier. We've never really, it sort of took anything and everything that we would have had to have addressed for communicable diseases and threw it into one disease. It really is an outlier. TB cases can actually live with 10. So if there's a positive TB case, they can actually live with 10 people. And those 10 people don't have to quarantine as long as they don't get sick. The focus is on the individual. Again, with pertussis, things in terms of we have testing, we have vaccinations. So if they're vaccinated, and again, we're looking at ways with diseases like that. Of those 135, aside from COVID, really those are diseases that are known. They have ways to test, they have ways to treat, we have vaccinations against them. They have a standard way that they act. And so that's why we don't have to take the extreme measures, because we can identify and work with them as individuals and prevent it from spreading so that it doesn't get to that. The problem with COVID was it was a new and emerging disease. And so we didn't know how it was going to act, how we needed to respond. So you always start much more cautious and then loosen back up. And so the initial goal was always just to control the virus. And then to get to the point where we have the ability to test, then we have the ability to vaccinate, and we have the ability to treat. And at that point in time, that's why you're seeing everything kind of loosen, is because now we're starting to figure out, okay, this is how this acts. This is how it's going to be transmitted. So that's the kind of way that we work. Our goal and our responsibility is really not to panic the public. What we want to do is we want to do basically what we do in the background is very much surveillance, identify, control the spread, and ensure that people can go about their work and go to school, go to work, go to the grocery store without the fear of getting sick, which in other countries that don't have high vaccination rates for some of the diseases that we're talking about, that's not an option. Here's a couple of options or a couple of examples of why it's so important for us to do this kind of work in these investigations. So looking at a hepatitis A outbreak that happened at a restaurant, 27 people are actually suing the outbreak facility. They had 10 people who were hospitalized and 4 deaths. These are not local, these are just examples that we're showing of different types of diseases. Looking at another hepatitis break, they had 11 cases, 9 were confirmed, 2 suspects, and they had a death, and the facility was closed for cleaning. In terms of looking at rabies deaths, so while 5 rabies deaths may not sound like a high number, that's the highest number that they've had in decades. There are things that are available, including rabies post-exposure prophylaxis, which can help individuals, but the problem is sometimes if people refuse that, then the outcome is death. Next slide. looking at things like, these are much more standard to what we deal with. Things like salmonella outbreaks. So you'll see those alerts that come out on the news. So they're saying, there was salmonella that was linked to lettuce or, that was linked to onions in this case. They had 892 illnesses, 183 hospitalizations. It's spread across 38 states. What you have to do is you find the way that you stop these things is you look and you do the investigations, and then you start to look for commonalities. So the last example that I'll give today is a situation where unfortunately we had a case that was investigated of infant botulism. And so a situation, this isn't that case, but what I'm saying is the situation could be looking at something like canned food. So maybe canned baby food that was sold at a farmer's market. This is all made up. I'm giving you an example. And say a lot of times when people buy canned food, they put it in their closet and they don't think about it. They don't open it right away. So maybe this person was the first person to open it and their baby was the first one to get sick. So then we need to start backtracking. Where did that food come from? Where did they get the illness from? Because if we can identify the source, then we can notify the community and say, if you have this, if you bought this baby food and this type of thing during this time period at this market, you can prevent people and say, throw those out. Like, don't use them because there's the potential it could be infected with this particular organism. So that is all wrapped up in what we do with communicable disease and why it's so important for us to have all of these capabilities to be able to address all of these diseases, because it gives us the ability to be able to limit the spread and to be able to prevent future illness with others very quickly. And a lot of times you don't hear about us because we're doing it in the background. We stop it before anything major happens. So I appreciate your time and your patience today. I know it was a long report, but thank you.
I have a question, Kelly. So in your, worst nightmare, what would be the disease or whatever that you would feel like there would need to be someone arrested or prosecuted over something? Give me a case.
Well, I can tell you
what that would be, or how would that work?
I can give you an example. So those types of situations or those type of lines are added in there as ways to ensure that we are able to, if we have an instance with a case that is contagious and will not isolate for a time period. I can tell you in the entire time that I have been here, we have not had to do it. We have not had to, I was going to say real quick, we have not had to take anybody to court. We have not had to go to have anybody physically restrained or quarantined or isolated.
Most people comply.
People just comply, literally.
Right.
So we have, so you'll notice in the communicable disease report, there were like 30 TB, latent TB cases, whatnot. So those individuals need to go through a series or a course of medications. And again, it's just, they don't want to get their loved ones sick.
No.
And so they just do it.
I mean,
And that's
correct me if I'm
really the
wrong,
case.
aren't they feeling sick with symptoms and they're, there's something going on? So
No.
they're going to seek medical help.
No, that's not true.
So not necessarily always.
Like what disease would not?
So
have symptoms?
that would be a perfect example. So with tuberculosis, you may have an individual who is contagious but not expressing outward symptoms at the time, but they may be able to pass it on to others. And so an individual would need to go through a course of treatment in order to be able to be not be in the situation where they would be if they are able to transmit.
So
to
the
others.
individual would be identified.
Correct.
Somebody would say, hey, you need to go through a course of treatment. And as long as they cooperated, everything's fine, right?
Absolutely. And literally, that is the way of it. Because I met with my communicable disease team this morning and I said, can you think of a time where we've had to take somebody to court, we've had to go for this, and we haven't. I mean, literally, we've had one situation.
Ms. Davis, I can give you a
It seems like it
perfect
resolves
example.
itself.
St.
This
Louis
just
City
sounds
has
very
prosecuted a
draconian.
number of people who have knowingly and purposely infected other people with HIV. And those folks have been convicted of criminal behavior.
Okay,
It
so,
happens, Ms.
so-
Davis.
so when we talk about this particular order, we should put HIV on there, because that's one that would be,
It's included in that.
this is so broad that it would cover everything, including your, bad polls.
Here's the list.
You have the entire list. That is the only thing that that order applies to. And the actual order itself excludes COVID-19
Not everybody will be compliant.
at the request of the board.
Okay, let's move on to new business. So we've already taken care of the architect's presentation. Next item is to act on recommendation of public health application.
I can completely make this one a lot shorter. I'm sure you all will be happy about it. Since the beginning of the COVID pandemic, we've gained about 20,000 social media followers across the various networks. We're on Facebook, Instagram, Twitter, LinkedIn, Pinterest, Snapchat, and TikTok. But again, just even looking at that, we're reaching about 10% of our county residents. Over the past couple of years, we've noticed there are limitations to social media. Not every resident is on social media. Not all residents follow our accounts. You can't force somebody to follow your account, obviously. It doesn't provide immediate information and notification. So it's a passive. You put it out there, and then if people find it, they'll see it. And it has changing algorithms. So we all know how with Facebook and everything else, you just never know what, if you click on, it's going to do. So what we began looking at is how can we get information quickly into the hands of individuals to make decisions on health. And how can we be progressive in terms of the technologies in our communications? So we actually have come across a public health app, which is something that people can download onto their phones. It gives the ability for more benefits of the app are that it gives us the ability to reach more residents because most residents have a smartphone. We can do push notifications for critical information. So something similar to like the emergency 911, where you can push out information if there's a situation. We can improve our client and resident engagement for messaging. So letting them know about new services and programs, as well as opportunities if we have openings, say with our registered dietitian. And she has open hours for doing some free visits for the day or whatnot, or if our wellness van is going to be someplace to help people within that community now. Easier promotion of our programs and services. Again, helping to really build our brand and our exposure. The funding for the project has already been set. We received a grant through the epidemiology and laboratory capacity enhancing detection expansion contract. They could make that shorter. They gave us $45,000 from a federal funding program to be able to develop a mobile app to improve public health communications. So this is a piece that has been put forward as something that they're really wanting health departments across the nation to look at. The project quotes, sorry, I'm trying to go too fast. The project quotes, so we contacted several companies to find out if they have a similar program to and how they could create a public health app. So there is a specific company, OCV, and correct me if any of this is wrong. Brianne has been spearheading the research on this. But OVC has a public health app, which we've got some information attached on. And I'll give you a little bit more on that one in just a minute. We also reached out and received bids from Worldwide Technology and Data Dynamics to be able to provide a program. In order to, we really like the OCV platform, and you'll see that on the following page. But again, it's very intuitive. It's very easy for individuals to download on their phone, gives them lots of access to all of our different services. But it was also the only, app or company programmer that was able to come in within our $45,000 range, and they were actually below what we were allocated for the budget. within their budget allocation, or sorry, within their bid, it was for the initial development. They gave us 3 years of the application running and doing all of the work with it, the marketing kit, regular maintenance and updates, as well as a dedicated technical support team. So we wanted to request from the board permission to go ahead and contract with the OCB company. The bids that we received and the information for the other companies are included in the packet. I don't know if I should say what the other bids were, or just that they were over. Okay, that they were over what we were.
So what are the dollars that we're actually looking at?
So the dollars would be 45,000. Their bid came in at 42,009.
And that's for 3 years. So that's initial development and then 2 more years to go with that. So they were really very comprehensive. They provided a mock-up. They answered all of our questions in depth, and everything came within the budget. And so
James, this is kind of in your ballpark. Do
I
you
was
have any,
anticipating questions from James.
do you have any concerns or thoughts?
I reviewed the bids and no, I don't. I mean, that one that came in under budget looked good. They looked like they crossed all the i's and dotted all the t's.
Would there be costs involved after the 3-year period?
So that's a great question. So the 42 that they initially did was for year 1, 2, and 3, which is development. After year 3, the cost is $8,995 a year to continue hosting the application and continued maintenance and technical support. Hopefully by then I can prove the return on investment and find some more grant funding to keep us going.
So we would just be approving your period.
Correct.
I'll make a motion, we accept the public health application.
I second.
OCV LLC for 42, I guess it is the word, what's the first, is it 45 in the first one total, or is it 42?
So 45 is what the grant was stated
It's
for
42,966, is that it?
986.
986, I'm sorry.
You said additional money for anything?
I will second.
I'm sorry.
I think that this is going to be extremely valuable. It's very difficult for people to find out where the vans are and the bus, the vans and the dental vans and the health vans. I think that this is a great tool that will really communicate what the needs are and where they're at in the community.
I'm super excited about it. Can't.
Okay, so we have a motion and second. Is there any other discussion?
Mr. Chairman?
Yes.
Now, maybe I'll direct it to this young lady over here since she's all excited about it. Would that put a bunch of junk mail in people's, how will that come across your phone automatically?
Great
Whether
question.
If
So-
you've joined it?
So this is a mobile app, so it'll be available for Apple and Android. So it is the user's prerogative whether or not they want to download it. So
Okay.
similar to when you go to the App Store and you decide, I think I want to play Candy Crush for a while, and you get sick of the notifications, so you delete it. Same concept. So you would download our app, and that's part of this that includes the marketing kit and campaign to really let folks know what it all is and what it can do for them. They can download it. They can choose to enable push notifications or disable. So we would be able to push out, hey, there's been a boil water advisory or something. But if Jenny decides, I don't want notifications from that one because I don't like notifications on my phone, and Kelly says, give me all the notifications, they have the ability to just determine that within their own phone. Again, it is, I personally am gonna highly recommend that folks download it, but it's not required, and it would be a free app in the store. So it would be something that someone would have to pay for or pay for a subscription.
Okay, and I'm just wondering how that would work, like, oh, just say one of the restaurants had something happen and there was salmonella or something. Is that something that you would put out on that app, that name of that restaurant, et cetera, et cetera?
So crisis
Is that gonna
communications
be a
works.
really,
No. So crisis communications works a little bit differently.
Really?
Even right now with like our social media and stuff, I don't go out there and listing like, hey, stay away from such and such restaurant.
would
We
you
usually-
still deal with that internally
Yeah,
and
so
not
that's
put
usually
their
where
name
that
out there?
case investigation comes into when we talk to who we need to talk to. The main purpose of the push notifications and what I envision
is being able to let folks know, hey, there's a service here. The wellness van is in DeSoto. If you need it, come get it. Or our dental van is headed to Fox School District in the next week. And I would be able to push that out, and anybody that has downloaded our app and say, oh my gosh, I didn't need to get my food in, I think I got a cavity. They have that application, and it's more so that we can get to people, which is really the direction of public health, hence, mobile units and all that jazz. It's really so that we can get to people instead of people expecting to come to us. So they have to go hunt through our Facebook feed because algorithms change and all that jazz. This would be a way, if they want it, they've got it. They have it right here. It's at their fingertips, and we would be available for potentially appointment scheduling, messaging, answering questions. It's really all encompassing, and I'm so excited about it. I will stop talking.
I was just asking if there was anything we could do with that extra $2,000. Could we carry that over for, to use past year 3?
That's a great question. I don't know if that funding would still be around after year 3. I don't know what the timing is for that. I mean, if it was to be utilized for this project, I can see it being used to help boost marketing around it. So letting the community know, hey, we have this app available, pushing out information, because that does cost more money. We do get some marketing,
That's a good idea.
but if we wanted to go above and beyond, that would be a way to spend that. Or, I mean, if it's not utilized with this, it could always go back into the project piece and be used for public health preparedness in general, the GMS program.
Okay, great.
Mhm.
Any other discussion on that? So we have a motion and a second to approve. I'm sorry, Tim, can you repeat your motion?
It was to accept the OVC bid, I think it was for 40 LLC for.
Except their bid for
You're
the
making
project.
you're making the extra work. Yes, for the mobile app project for $42,986,000.
All right, thanks. All in favor, please say aye.
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 Anyone opposed? Thank you.
Thank you. You just made Brian's
Yes,
day.
thank you.
We have been talking with the state and are planning to do a board of trustees training at our February meeting in conjunction with our February meeting. It will extend the length of our meeting, so we will try to keep the agenda tight. But the training is something that is provided to boards across the state from the Department of Health and Senior Services, and it goes through everything from sunshine training to the statutes and laws that are applied to the public health departments, as well as the responsibilities of board members and just walking through all of the different pieces of what a health department is and how it interacts with the state and the different responsibilities that are involved in it. So we are going to be planning that for the February meeting. Our meeting is normally at 3 o'clock. And so they said it will probably be a 2.5-hour training. So we will provide either something, and we know that most of you guys are coming from work, so we can provide dinner or whatnot, box lunches, to be able to work around that. But I was wondering if you guys prefer to have it prior to 3 o'clock, or if you want to do it immediately following the board meeting at 3.
I don't have a preference.
Why couldn't we do that virtually at home? Meeting, that training.
She's actually going to be coming here to do the training.
I would prefer to do it after the meeting.
And the meeting's still at 3 o'clock. Dr. Henry?
Why would that mean you have to have a hard stop for the meeting time in order to make sure that they're in and out?
Yeah, that's a good point.
She just said she worked with us as far as the time. So I can tell her to be here closer to say 4 o'clock, depending on what our agenda looks like. We can probably estimate a time for her and then just add her to that portion. But that would be helpful one way or another. And then the other piece of that was we can broadcast the meeting and the training if you like. Okay, so it sounds like, does it sound like then it's okay to go ahead and plan on the 3 o'clock board meeting and we'll do the training after that? And I will get back with you with more information, once I have it from the trainer.
I'm fine with that.
If we're gonna do what the AG's office asked us to do about the sunshine law, I know they're gonna touch on it, but I think we need the thorough training that they provide. So is that gonna be set up as well?
That actually, I was gonna say, that is part of the sunshine law is the training.
Okay.
So. Okay. The next item on the agenda is the communicable disease order that is in front of you. So a couple of points I wanted to make prior to us, or prior to making a decision on the CD order. So, one, even though we were, we had a vote last week, we were having to have special meetings in order to be able to do this, prior to, because it was on a 30-day schedule. In doing this order today, a couple of changes can be made. One, in the previous format, it was costing us about $4,000 every time that we have to do the order. Under 192-300, anytime you do an order, you have to post it in the newspaper for 3 weeks. And so it was $4,000 to post it for 3 weeks. And that was two times, was 4,000 for 2 times. Thank you.
And what was the example of that? What were you posting for?
The actual order. So you have to physically put the entire order into the newspaper. And so we have to pay for that space in order to be able to do it, but that's just part of that.
Sunshine law.
Sunshine law. So with this order that is written today, I want to make the distinction. 192-300 has the with the statute for 67 that came into play. It's because of general applicability of the rules. And I'm going to look at Christy to correct me if I'm making any of this wrong. Our orders aren't for general applicability. They're for individuals. And so again, thinking back to that list of diseases that you have in front of you, all of the work that we do, the case investigations, if we ever had to do an isolation or quarantine or whatnot, or some kind of control measure, it would be focused on an individual. That doesn't apply to 67. So it would allow us to do individual orders from this new order, and we can just approve it, and then we don't have to keep coming back every 30 days. The one thing I do want to make the caveat on is, one, we have not had to do a isolation or quarantine on other individuals. So again, COVID was a unique beast. COVID is not included in this order. The second piece of this is that we've only, in the entire time I've been here, had to do a quarantine on a facility twice. And both of those were a separate order. It's specific to a facility. It has a specific end date. And it had to be brought to the board to be able to implement. It was not something that I could do on my own. So the implementation of this order is not going to give me the ability to shut a school down. It's not going to give me the ability to go into a long-term care facility. These are specifically so that our communicable disease nurses can work with individuals and do the case investigations and work with them on that piece of it. Any order that would look at something larger than that would be something that we would come back to the board. We would come back to the board with a unique document that you would make a vote and make a judgment on.
And that type of order, by the way, because you're talking about closing down a school or shopping center or any kind of facility, that is subject to the new chapter 67 statute. So that would, if it needed to go for longer than 30 days, that would have to be retained for 30 days. But these orders are orders of general applicability, which means that they apply to the community at large. They're not targeting any one specific individual or any one specific facility, so they can stand on the books and not have to be reviewed every 30 days.
So actually going to this method will enable our staff to do what they need to do for communicable disease, and it will mitigate the need to keep coming back every 30 days and spending $4,000 every time, or $2,000. That's what it is each time we publish the order.
Where do you see it in here excluding SARS-CoV-2?
It is, I apologize, I don't have a copy. It's in there twice. Go ahead, Tim.
I was just gonna make a motion so we can discuss it.
Oh,
I make a motion that we adopt the JCHD communicable disease order, whatever the numbers are for that.
It is 22-01-27-01.
Thank you. Okay, nope, that was my motion.
27.
I second.
Thank you.
Okay.
Okay, now it's okay to discuss.
22-01-27-01.
Okay.
You're welcome. Ms. Davis, if you look on page 2,
Fourth paragraph.
1, 2, 3.
And then it's also on page 3, second paragraph.
Well, I'd like to see, not only with the exception of COVID-19 and any future upper respiratory flu-like viruses. Because, you know, right now they're calling the present strain Omicron. You know,
Omicron is COVID. It's a mutation of COVID.
okay, and, you know, but let's just say another strain comes out, you know, and, you know, are all these falling under COVID?
So Delta is COVID, Omicron is COVID. So it all is. So Omicron, Delta, all apply to COVID. So that is being.
It is a variation of the virus. It is not a separate virus itself. So
Thank you.
it fits under the umbrella of COVID-19.
You know, I mean, we've seen over the past 2 years, you know, the whole course of this thing, and thank God it wasn't like we thought it was gonna be. You know, people did not drop dead like flies, you know. Wouldn't we feel more comfortable in saying that COVID-19 and any future similar viruses?
Actually, no, you can't, because we're doing this in the Florida statute that does specify out particular diseases. And that's why you can't just make up a catch-all disease that you want to throw in.
Well, it's on this page here. It says, severe acute respiratory syndrome associated coronavirus, SARS-CoV disease. That right there, if we just take that
Do you
wording,
see any
I would
future
feel a
respiratory
lot more
illness that's
comfortable.
like that?
If
Wait,
that
Ms.
wording
Davis,
was
on that.
put
So-
right here.
Okay,
There are
Miss-
specific case definitions for all of those. Ms. Davis.
that is the one that is excluded, ma'am.
Ms. Davis, back in December, whenever we had the initial order, you asked that the board consider taking COVID-19 out of its order. The board did that, and then you abstained from voting on the amended order that you asked to have revised. And then when last week as well, when we renewed it, you did not vote. So this order has been.
I'm still trying to figure out what this
I'm trying-
is. Sorry. I don't feel 100% comfortable with it, right?
Hold on.
Because this was changed in order to accommodate your specific request and your specific problem with it.
Right. So what I'm saying is the wording in number 8 on this page is the wording we should put here in the 4th paragraph. Instead of just saying COVID-19, it needs to say all of that.
That is the disease.
Yeah, it's the virus.
That is the virus.
Well, can we at least add severe acute respiratory syndrome associated viruses?
That's SARS-CoV-19. That is what this says, COVID-19.
You can't guess the future. You can guess something that's not here. That would be a whole nother game. That would be
Miss-
something that would.
I was gonna say, what you're asking for has been completely accomplished by this draft.
So do you know what this really?
What would it hurt though to put those words? I mean, if, you know,
This is not COVID-19.
so anybody reading this that's published in, is it gonna get published in the paper?
Yes.
Anybody reading it will see that, oh, good, we don't have to worry,
It's
you
not-
know, if this comes up again in
COVID-19.
2 years that, you know, people are gonna
If it's
not be able
something,
to go to school, they're not gonna be able to play their sports, they're not, you know.
Okay, so again,
quarantined
that
at
doesn't
home.
apply to this order.
Yeah.
So this-
The schools and mission have their own orders about participation.
Correct.
this is about individual. This is about somebody getting, say this, I've got a perfect example for you. You have horses. If one of your horses gets sick, you take them and quarantine them. Get them away from everybody else, so they don't get sick. That's what this is about, not taking all your horses and quarantining all of them, just taking the one over there and going over here, let everybody else go do their thing. For a little short time until they get well, then they're back in their general
I
population.
think what the people are gonna be concerned about, and hear me out, is that someone's gonna come in their house, handcuff them and take them off to some sort of a camp where they have
No,
to stay and
no.
live until they're over, quote,
God.
and they're not even having any symptoms.
And Ms. Davis,
I mean,
again,
it's,
this
you know,
has,
it's gotta
and
be
it-
That's way
something
out, that's way out of
that's
line.
symptomatic.
that is, but again, that's hyping up a
contagious.
situation that has literally not happened.
Ever.
I was gonna
It's
say, so
happening
if
in
you.
other countries.
Well,
It's
Ms. Davis,
what
this
people
isn't other
worry about.
countries. This is
Honestly.
Jefferson County. And as we are talking about, we are focused on Jefferson County residents and protecting the residents of our community. So we are focused on what we are able to do here. And we, again, I mean, I don't know how else to, we literally have taken a disease that is listed under number 1 of the most communicable disease, our most transmissible and high mortality diseases out of an order to deal with communicable disease. Literally, it's not in here. We can pass this order. Our staff need to be able to protect our residents. That is what this is focused on. Our people need us to be able to have these abilities.
I have a question about
I'm just asking if I can put in there.
the future course of action on this. Christie, once these legal cases are resolved, and I'm assuming at some point the decision's gonna be made that this is what health departments do, that's what they can continue to do. If that happens, do we need to keep this in place, or?
You would not need to, you wouldn't be required to. And right now, we have a motion for stay before the Missouri Supreme Court, which I'm fairly confident will be granted. And if that happens, then the DHSS regulations all remain as written prior to Judge Green's ruling, and we would have them back into those as well. But this gives you the stopgap protection of what we would need to be able to continue to do what we need to do until we actually get a ruling from the Supreme Court, either reversing Judge Green's decision or sending it back down with instructions on how to rule it differently.
So we're just gonna need to wait and see what happens with that?
Yes,
Okay.
the application for transfer has been filed by all of you.
I'm gonna call a question on that, so. Have a motion and second to adopt order 22-01-27-01. All
Mr.
in
Chairman,
favor? Yes.
before you ask for the call, I'd like to amend the motion to add this phrase in number 8 to where it says COVID in that 4th paragraph there. The phrase exactly is, here's what it would say. It would say, with the exception of COVID-19 and severe acute respiratory syndrome associated coronavirus SARS-CoV disease, instead of just COVID-19. Replace COVID-19 with exactly what it says in number 8, severe acute respiratory syndrome associated coronavirus SARS-CoV disease. Replace that.
So you're making.
Doesn't our bylaws say that we can't-
To amend the motion?
It's a motion to amend the order that is on the table. It would need to have a second, and then if it's a second, and then the amendment would have to be voted on.
Just strike what is there and put this in place of it.
Does anyone want to second that? Okay.
What can it hurt?
There's no point in doing it, Ms. Davis. Okay, so that motion to amend the motion dies. So we're back to voting on the original motion, correct?
Well, in the wording here, sir, just want to point out to you, it says COVID-19, and. Proceed.
Did you call for the?
Yes. Okay, so all in favor of adopting Wolf, please say aye.
I,
Aye.
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 Anyone opposed?
Myself,
Okay, so. Pass, 4-1. Okay, have a request by a board member for 3 minutes.
okay, so looking at the report, I believe it is Brianne that does this, am I correct? Brianne, you do this, okay, so you do a good job of this, thank you for doing that for us. I want to point out to you that, this most recent report we have, that there's been 48,486 positive cases since this began, and a total of deaths of 416, as we know. And if you get your calculator out and you divide, I already did it, so you can follow me with your calculator if you like. If you take 416 deaths, divide it by 48,486, you will come up with 0.0085. And if you multiply by 100, like the young lady taught us a few minutes ago, which I did, the same thing as moving your decimal 2 places to the right, you get 0.85%, which is not even 1% of the total number of positive cases became deaths. So the next thing I wanted to mention was that our population is approximately 225,000 people in Jefferson County. If we take the 416 deaths since the beginning of COVID, and we, again, divide that by 225,000 now, the population, what we come up with is 0.0018, or 0.18% have died, less than 1%, 0.18, which is 0.1% of our population in Jefferson County in 2 years has died from COVID. Again, thank God that this is not what it could have been. Thank the good Lord for that and all the efforts. And moving on here to okay, so one more thing there. That's 0.1%. 0.1% of our population. Okay, the third thing. There was such a big deal made about schools and about the kids need to wear masks in schools. They need to get their vaccination in schools to be safe, to be safe, to be safe. According to the stats
Ms.
that's
Davis,
been
you
given
have
to
1 minute
us
remaining.
from, I don't know if it's from the state or where it's from, but it says clearly, age range 0 to 9 fatalities, 0 in Jefferson County. 10 to 19, 0 in Jefferson County. So why are we bothering these teachers, these principals, these coaches? That does not need to be done. We've determined that. We've been through this for 2 years. This part needs to end. The last thing I want to say is that looking at the infection rate comparing Jefferson County to St. Louis County, to St. Louis City, and to Jefferson County, infection rate over the past 2 years has averaged out at, in St. Louis County, who is very heavily masked, very heavily mandated, and all of that, even people going into the stores with their mask on, their infection rate is 1.06. Guess what ours is? 1.02. And it's as relaxed as it can be in Jefferson County. You can go anywhere and hardly see any mask on anybody. So in effect, my conclusion, take it for what it's worth. We really didn't accomplish anything by wearing masks, whether it's at school or, you know, around town or anything. It's a virus. It's doing what a virus does. It spreads, it builds immunity, and it gets over with. We do have treatment, like Kelly said. We have treatment. We have the hospitals were able to handle it. If they're not, the governor's set up to bring people in and help out. We never did have to use that.
Okay.
Thank God, thank God.
Okay. Time's up.
May I have a floor, sir?
You got 3 minutes?
Ms. Davis, I'm really not sure we get your information. I did pull some information myself on Missouri cases and stuff. I've got 17,000 deaths, a little over 17,000 deaths.
Where?
In state of Missouri.
No, we're not talking Missouri. We're talking Jeffco.
Oh, okay, I'm sorry, I didn't pull those numbers out.
No,
The
this
state of
is
Missouri,
Jeffco, sir.
the state of Missouri death rate is 2.02%. The United States death rate
That's
is
Missouri.
Ms.
United
Davis, this is 10
Yeah, thank you.
Sorry.
United States death rate is 2%. I know it's not, I know 2% is not a big number. That's 2 out of 100. I'm correct on my math. But it's still 2 out of 100. We should have a little compassion for those people who do pass away from it. And it's not just a bad cold, it's pretty bad. So I really kind of take some just bothers me when you say that, because it is bad. So we've had 2 people die recently of it. So I think we need to be just a little less flippant about the death on this. Now, I do agree with you that we have a number of things that are in place that we didn't have anything to do with, but that are in place by the federal government, and I'm a little aggravated at them. They don't have the medications like they should be. I'm aggravated they don't have some of the other therapeutics that they should have in place. They're not pushing these out. That's beyond us. I can't force them to do what they need to do. That's a whole different game. But I believe we're right there on the precipice of really being done with this. We can't do anything with the school. The schools make their decisions. We as a health department have to support the school with whatever decision they make. We don't control the schools. We haven't been controlling the schools.
There's lots of,
Ms. Davis, it's
We don't
need to say, sir. And then I have a chance to read
Excuse me.
it.
Oh, you don't have a chance.
Yes, I do. Wait a minute, here, you want to read it?
All right.
I just read it. the other
Okay,
day.
I'm done. I've been
Completely.
interrupted. Okay, I'm
Anyone
interrupted
else?
I
again.
want you to finish completely.
Nobody interrupted you.
May I have the floor, sir?
Yes, ma'am.
So, Ms. Davis, one thing I would caution you about looking at the deaths is deaths are a lagging measure. And so if you've noticed with the case counts and hospitalizations that were shown to you throughout the presentation today, and you saw the enormous wave that came with the Omicron variant, one thing that we have been warned consistently is not to take the death numbers immediately as they are, because they lag behind. So it will be something that will be coming over the next couple of months that you will be seeing. A second statement I would like to make is that while there seems to be a lot of push as far as the continued issues saying that we are ordering people or that we're ordering masking and those kinds of things, I again caution that we are beating a dead horse at this point in time. We need to move beyond the fighting. We need to move beyond the stern drawn lines. The community needs to move past COVID. And in order to do that, we need to be able to move past the fighting, be able to move on and make educated decisions, utilizing the science and the data that we have in front of us. I think that at this point in time, we have immense resources within our community. Our community has been very well informed of what they need to do, and they have access to the things that they need. So I believe that the most important thing that we can do as a board as a whole is to help our community move past this and to be able to one, access reliable, truthful information, accurate information, and then 2, to be able to help as we are working our way out of this pandemic to access and connect our community to resources such as mental health resources, the health resources that they have not been able to or have not been accessing throughout the pandemic, those kinds of things. So I encourage us to take a step forward and really go back to the true nature of public health in terms of our prevention and positive approach with our community. So please help me to start rebuilding those bridges. That's all.
Mr. Chairman, point of order.
Just a minute, ma'am. Anyone else have any comments?
I have comment.
I'd like to make one. Is whether or not we think that your pronouncements are accurate or not, I'm not going to argue that. But a couple of things I think everybody needs to keep in mind is that as long as this virus is continuing to circulate, as we've already seen twice, it can mutate and become, as we've already seen, more transmissible. It could become more deadly than it is now. And so what we really need to do, as Director Volmar said, is do our best to stop the transmission of the virus. And I think if COVID has taught us anything else, it's that we can't put a wall around any given area. To talk about Jefferson County is really not productive because 2/3 of our workforce work other places. People shop other places. People visit other places. And again, as long as the virus is circulating anywhere, the virus is going around the world very quickly. Jefferson County is not immune. And as long as it's circulating, it's not only a problem now, it could potentially be a very much worse problem. So, you know, I just can't imagine why people want to discount what's already happened in terms of deaths, in terms of illness, in terms of all of the effects of this virus. But I think the thing we need to be concerned about is it can still get very much worse very easily.
Mr. Chairman?
Yes.
You know, what's going on right now, you know, I hear what you're saying. You know, yeah, we go outside of Jefferson County. That's why I did that comparison, because, you know, we don't St. Louis County, Jefferson County. But the rates are the same, basically. It's 1.02 or 1.06, and we're actually less than them. But the thing is, you know, we've given people the chance. You know, if they want to get the jab, they can get the first jab, the second jab. But people aren't buying it anymore. Now, you know, they're offering a third jab, and people are saying 17% of Jefferson County are saying, "Hell no, we're done." You know,
Perhaps it's because we're
the doors have
calling it a
been
jab.
open, people could come in and go wherever, and they're not doing it. They're done. They're done getting jabs. There's one more thing, 46%, hang on, 63% you say, okay, are hospitalized that are, quote, non-vaccinated. So that means that over 40% are double vaccinated people in the hospital that were promised that, you know, if you take these double jabs, you're not going to get it as bad as everybody else.
Mr. Chairman, may I make a correction to that
So-
statement, please?
Yeah.
One, no vaccine is 100% effective. And so no one,
Thank you.
I can tell Ms. Davis, thank you for letting me have the
I
floor.
agree.
So all vaccines have a degree of less than 100%. At this point in time, all of the vaccines that have been approved where people have received the double dose have been extremely effective with Delta. They still have shown protection in the case of Omicron, the booster dose has been more effective, whether that is because it's a more recent dose or it's because it is more effective against Omicron. It does show a market improvement in terms of at least 90% in the case of our numbers, protection against getting the virus. So I think to state that getting the vaccine is not worth it, and then as well to state that people are being promised that they would never get the disease. Those are two things that a health professional would not do. So I do encourage,
Can I
Ms.
ask you a
Davis, I
question?
do encourage,
As soon as you're done talking, can I ask you a question?
if I can actually get done talking. Ms. Davis, as stated, again, it is extremely important, the verbiage that we use. So as part of that process where I'm asking you to move on and to help make a more positive difference in our community, part of that is in the verbiage you use with your fellow peers. It is not a jab, it is a vaccine, it is an immunization, it is a protective dose of medication that is given to prevent disease and has been extremely successful throughout the use of it in this pandemic. Thank you.
So,
Chair, I got a point of order. I'd like to close, I'd like to make a motion to close discussion on this topic due to the fact, unless Ms. Amber or Mr. Prater has anything to add to this, but then we close on the subject. Because there are no mask mandates and no other mandates, but it's the subject matter needs to close.
I don't have anything.
Everyone's had their chance to make their say, so let's move on. So we have one more item, in open session, updates from our council on status of sunshine law request to the Attorney General.
So I wanted to let you guys know that we have made several requests to the Attorney General's office back in December, asking for certain documents. Both Ms. Walner and Mr. Deal made requests. We sent 4 in total between the two of them, and the Attorney General's office responded. We're not going to have responsive documents back until mid-February, I believe.
For one of them.
For one of them. Didn't respond at all on the others. We responded and said that while we understand that we were asking for a lot of documents, to wait till February to produce responsive documents was not reasonable. We were allowing them additional time that we requested within 10 days. And we had no response to that request and have had no responsive documents sent us by the Attorney General's office. So I know that one of the things that we deal with from a public perspective is whether or not we are complying with the sunshine law. We've gotten the letter from the Attorney General's office that he sent to every public health department in the state, and then the ones that he sent to the school districts in the state, and then now he is spending public funds to sue school districts that in turn have to spend public funds to defend those lawsuits. But I think it's important that the public also realize that we're dealing with a law enforcement official that is not actually complying with the statute that he is charged with enforcing. So I just want to let the board know as to those requests, they'll definitely keep you updated once we have response.
I'd be careful making those kind of statements, Ms. Coleman, because the Attorney General, it's a lot more education than all of us put together, and it remains to be seen, and the judges will decide.
Thank you for advising me on how to speak. I am 100% comfortable with everything that I just said.
Yeah. I make a motion to go into closed session, correct?
I do not believe that we will need a.
I'll pull that back off then.
No,
I make a motion-
I think we.
In response to Mr. Gill's question, I actually have to do on the Robinson case.
I make a motion, we adjourn.
Wait,
Oh,
there was
I'm sorry.
one other item passed. Is that still on there?
Oh, act on a recommendation, of building subcommittee?
I did.
Okay.
That was put on the agenda in case the board wanted to go ahead and move forward with,
Sorry.
with
No, you're right.
the recommendation on the architect firm, but if the board wants to have additional time to consider that proposal, then that can be tabled. Just put on here in case the board wanted to do that today.
I'll make a motion, we go ahead and select Arch Images as the architect, or at least I guess, do we have to go in?
You don't have to vote to close.
No, I'm saying is, I guess, do the final negotiations on cost to that. How do I need to word that? Because we don't have,
You would go ahead and move to accept the contract.
okay, move to accept contract for Arch Images.
Second.
Okay, so there's a motion and second on the floor. Do we have discussion on that? I guess one thing I would ask is whether the committee members feel comfortable that all due diligence has been done to choose the best option to go ahead.
And we've spent a lot of time reviewing the different architect proposals, and yes, I feel like it's been vetted.
Yeah, we reviewed, what was it, 20 of them, I think? 10, 15, how many?
11.
11, I'm sorry. And then we narrowed it down to 3, then we brought those 3, interviewed those 3. Some was on Zoom, some were in person. And then filled out the score sheet on that, and we came up with our images, so I'm comfortable.
I'm comfortable with it. I mean, that's the task we have given the subcommittee to do, so I accept the recommendation.
We did follow the standard for selection based on qualifications as advised by our attorney. There's a whole process that we go through, and we follow the steps.
Any other discussion? Okay, so we have a motion to accept the contract of OCD LLC. And we have a second?
Wait, our images,
right?
No, our images.
It's our images, you're one back, it's our images.
What would be?
It's Arch Images. Oh,
I'm sorry.
You're back on-
Yeah, I'm looking at the
You're
wrong
back on the
one.
public health app.
You're doubling down on my app.
Let's do that again. No.
I don't think there's a contract. I think we're going into negotiations, right? Is that what we would be doing?
But you would have a contract with Arch Images to become your
Yeah.
architect.
So negotiations for a contract.
Yeah, I'm sorry. Our Tim.
He's really getting your app. I know, I'm very excited.
Did we have a second?
James.
I second it.
Okay, thanks. Any other discussion?
Mr. Chairman, was there supposed to be a board member assigned to that? He was asking that a board member be present at the designing meetings.
That hasn't
But
been
that's
done
a
yet.
subcommittee.
I would be interested if there's,
Okay. We'll
to
see,
do that.
we'll see how.
And maybe we could share that. We wouldn't have to, one person do it all the time, because it sounds like a lot of meetings.
We'll
Maybe
see
take
how
turns.
it's gonna go. You have a meeting set up at this point?
no, there won't be any until we're done with that.
We gotta negotiate our contract and make sure.
So you're talking about the process that you discussed at the meeting. Yeah. I mean, the committee's gonna be involved. So there are gonna be board members. Is there a problem if she wants to sit in?
There would be then
Well, there'd be 3 board members.
Oh, that's true.
I think he said have one board member come to that,
He recommended,
along with,
we have a board member, but we'd already discussed that we would have a building committee that we've already been involved with, but I'm sure there'll be times that we can present to the board.
Yeah.
As well, he
We'll
did
be
mention
bringing
that.
everything back, you'll have
Yeah.
plenty of time for input.
I was gonna say, that they're also planning to have communications with the
Yeah.
board, they're gonna communicate with staff, they wanna do interviews to find out what everybody is looking for and the different pieces.
All right, I'll call the question then on approving
Arch Images.
Are we gonna phrase that to negotiate with them,
Accept the
To
contract.
accept the contract.
to accept their contract or to accept the contract with them?
Yes.
Okay. So all in favor of that, please say aye.
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 Anyone opposed? Okay, that passes. So we have nothing else?
just wondering what happened to, we were supposed to all wanted it every month, one of our board members be assigned to come up to the health department.
Yeah.
And that ball kind of got dropped, notice in our bylaws.
It didn't get dropped. People.
Everybody was assigned a month.
I had a schedule, but I guess that ran out in, the end of the year. So I'll put another schedule together and send that out to everyone.
I make the motion we adjourn.
Second?
Everybody's seconding.
Favor? Say aye.